You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology. And this is This Week in Cardiology for February 11th, 2022. This week, LDL cholesterol equations, stroke interventions, post-PCI antiplatelets, the transitive function and network meta-analyses, and lipoprotein a. First topic is Jack has published a paper looking at the clinical implications of different LDL cholesterol estimates. Now, I think we all know this, but nearly all LDL measurements are actually estimates using total cholesterol and triglycerides and VLDL. There are three equations used. The most common is the Friedewald equation, then the Sampson and Martin-Hopkins equations. Direct measurements of LDL cholesterol are lengthy and expensive and not routinely done. The other relevant fact here is that treatment guidelines often turn on driving the LDL cholesterol below 70. So if you underestimate the LDL, you may undertreat some patients because you think the LDL is in that range when it actually isn't. Well, the study group, first author Aparna Sajja, did an electronic health review of patients who had heart disease and triglyceride levels less than 400. They estimated the LDL cholesterol in about 146,000 patients using the three equations. Now, patients were described as concordant if the LDL was less than 70 with each equation. Patients were described as discordant if the LDL cholesterol was less than 70 for the index equation, but then greater than 70 with another equation. The four main findings were that the Martin-Hopkins equation consistently estimated higher LDL cholesterol values than Friedewald and Sampson. The discordance rates were 15% for Friedewald versus Martin-Hopkins, 9% for Friedewald versus Sampson, and 7% for the Sampson versus Martin-Hopkins comparison. And discordance increased at lower LDL cholesterol cut points and in those with elevated triglyceride levels. And among patients with triglyceride levels greater than 150, a 10 milligram per deciliter difference in LDL cholesterol was present in 67%, 27%, and 23% of patients when comparing the Friedewald versus Martin-Hopkins, Friedewald versus Sampson, and Sampson versus Martin-Hopkins, respectively. Now, my comments on this is I like this paper because it's a nice use of observational data. The authors make a reasonable conclusion that, quote, clinically meaningful differences in estimated LDL cholesterol exist among the equations, particularly at triglyceride levels greater than 150 and or lower LDL cholesterol levels. Now, here's how I see the importance of this paper. If you have a person with known vascular disease, especially if the disease is substantial, and the patient is otherwise in good shape, it makes sense to do as much as feasible to reduce risk. Now, note the qualifier, as much as feasible. I mean, if you have a person with multivessel CAD, and the LDL by Friedewald comes back at 69, and they're on 20 of atorvastatin, it makes sense to bump it up. That is easy, and it's a low burden to most patients. If you have a patient with a similar amount of coronary disease who has the same LDL of about 69, but is already on 80 of atorvastatin and ezetimibe, and the next step is PCSK9, and they're already on 7 drugs and living on a fixed income, well, that's a different story. The accompanying editorial, first author, Kevin Mackey, is excellent. You all should read this editorial and save it, because if you're like me, the specifics of these equations will be hard to remember, and the authors get into the nitty-gritty of the equations and tell us which is best in certain situations. Here are some easy take-homes to remember about this paper and this topic. LDL cholesterol is an estimate. There are 3 equations. The most common equation, Friedewald, tends to give lower LDL readings when LDL is very low or triglycerides are greater than 150, and in these cases, we might consider use of other equations. For patients with triglycerides greater than 400, the Sampson method may be the most accurate. For those on intensive lipid-lowering therapies with LDLs less than 100, the Martin-Hopkins method may be favored to reduce the risk for undertreatment, given that no safety signal has been identified for very low levels of LDL. Now, finally, these were patients with established heart disease, and this pertains to treating to goal LDL. For primary prevention statin decisions, I don't know that these equations make that much of a difference because for these patients, I see this decision as so simple. You enter their numbers in the risk calculator, you give them their 10-year risk on, 10-year risk off statin, and then patients can decide if that spread is worth the disutility of taking a pill every day, and people will feel differently about it. Next topic is on acute stroke care. Now, a quick note on an important trial in interventional stroke care. New England Journal published the result as a simultaneous publication from a presentation at the International Stroke Conference. This was a big paper, important topic. This was endovascular therapy for stroke, and it generally not done for those with big infarcts in the MCA region. And the worry is, of course, is that patients with big infarcts will bleed after reperfusion and get worse. However, both endovascular therapy and our knowledge iterates, and Japanese investigators decided to study the role of endovascular therapy in these infarcts with a large ischemic core. Now, the only way to study such a decision is with a randomized controlled trial. There are 100 patients in the endovascular plus medical therapy group versus 100 in the medical care arm. The primary endpoint of these stroke trials is usually the percent of people who have a modified ranking score of some low level. And in this case, it was modified ranking score of 0 to 3 at 3 months. Now, just briefly, modified ranking score is 0 is no symptoms. Level 1 is no significant disability, despite some symptoms, completely able to carry out all usual activities. Modified ranking 2 is a slight disability, unable to carry out all previous activities, but able to look after one's own affairs without assistance. And modified ranking level 3 is a moderate disability requiring help, but able to walk without assistance. So the results of this paper were clear. 31% had a modified Rankin score of 0 to 3 with endovascular therapy versus only 13% with medical care. Any intracranial hemorrhage within 2 days, 58% endovascular care, 31% in the medical arm, or an 85% higher rate. Both of these were statistically significant. So it kind of sounds bad that the benefit in terms of modified Rankin was outweighed by the intracranial hemorrhage risk. But recall that modified Rankin score is a functional score. So if more patients are functional at 90 days, then the higher intracranial bleeding must not have been clinically significant. And in fact, the number of symptomatic intracranial hemorrhages were quite small and not significantly different in the two groups. So I see these results as statistically robust and clinically meaningful. But it is only one trial. It had small numbers of patients. It was carried out in Japan where they used low doses of TPA. The authors note that if TPA had been used more often or at higher doses, the outcomes might have improved in both groups, but there might have been an increased percentage of patients with intracranial hemorrhage in both groups. Now, you all know how I feel about TPA in acute stroke. I think it's dubious. So perhaps this trial was so positive because of the low burden of lytic therapy. And I highlight this paper on this podcast because interventional stroke care looks a lot like interventional cardiology looked a few years ago. I think we're going to be seeing more and more interventional stroke procedures, and perhaps there will be a need to increase the number of stroke interventionalists. And I also wonder why there is such separation in the fields of brain and heart interventions. Okay, next topic. What to do after PCI for acute coronary syndrome and the network meta-analysis. So the journal JACC Intervention has published a network meta-analysis looking at the reduction of antiplatelet therapies after PCI and stenting for patients who have acute MI. The paper is one of the most complex papers I have read in years, but I want to first give some background. PCI for acute MI is one of the purest treatments in all of medicine. It's truly spectacular, and younger listeners simply don't have the perspective that us older folks have. I get the sense that younger people think PCI for acute MI, in which a patient suffering from acute cardiac injury gets off the table with a Band-Aid on the wrist, is normal. But in medical school, where I went, University of Connecticut, we treated acute MI patients with morphine, aspirin, and Swan-Ganz catheters. Then in internship and residency, we gave lytics and we prayed the artery opened and the patient did not have a catastrophic brain bleed. But here's the thing, even though PCI for acute MI is a beautiful, spectacular therapy, there is still the issue of how best to keep that metal cage from occluding while minimizing major bleeding. Major bleeding is important to minimize because it's associated with higher death rates. The current guidelines recommend 12 months of dual antiplatelet therapy for patients who have PCI after an acute coronary syndrome. But of course, stents have iterated. Newer stents have thinner struts and are less prone to clots. And then this has driven the idea to reduce dual antiplatelet therapy so as to reduce bleeding and still prevent ischemic events. The whole thing really boils down to the clot, bleeding, tension inherent in any antithrombotic therapy. It's the same issue with stroke prevention and AFib with oral anticoagulants. Now, there are two ways to reduce the burden of antiplatelet drugs and hence bleeding after a stent. Now, you can de-escalate the dual antiplatelet therapy, or you can shorten the duration of dual antiplatelet therapy. To de-escalate means changing the more potent P2Y12 blockers like prasugrel or ticagrelor to lower doses of those drugs, or to change them to the less potent drug clopidogrel. Now, shortening the DAPT is self-explanatory, but of course, you can shorten the DAPT in two ways. One is to give aspirin as single antiplatelet therapy, and the other is to give P2Y12 inhibitor alone. Now, here's the problem. Trials have compared de-escalation to standard DAPT and shortening DAPT to standard DAPT, but we don't have the massive three-arm trials looking at all three of these things directly. So we sort of have an if A equals B and B equals C, then A equals C issue, or the transitive property. Well, that is where this network meta-analysis comes in. Italian authors, first author Claudio Lodani from Catania, Italy, which is the second largest city in Sicily, meta-analyzed 29 studies, including 50,000 patients. They analyzed the results using frequentist stats, which is, of course, no prior assumptions, and Bayesian stats, which incorporate priors. The primary endpoint of interest was all-cause mortality, and secondary outcomes was something called net cardiac adverse events, and of course, major adverse cardiac events. The idea here was to study short DAPT regimens versus de-escalation. Well, the results of this indirect comparison of short DAPT and de-escalation uses standard DAPT as a common reference. It can be summarized as follows. Three things. Both short DAPT and de-escalation carried a similar risk for death and cardiovascular death. Second, short DAPT significantly reduced the risk of major bleeding. It ranked first in the Bayesian hierarchy of treatment strategies with respect to this endpoint, and increase the risk of net adverse cardiac events. Third, de-escalation significantly reduced the risk for net adverse cardiac events, increased the risk for major bleeding, and it ranked first in the Bayesian hierarchy of treatment strategies with respect to major adverse cardiac events, MI, stroke, and stent thrombosis. Now, again, recall that this is not a direct comparison of short DAPT or de-escalation versus standard DAPT, but an indirect comparison. Now, at first, I was wondering why de-escalation would increase major bleeding, but then I think this was because de-escalation was compared to short DAPT. As the authors note then, short dual antiplatelets may be a better strategy than de-escalation in patients with a high risk for bleeding. However, de-escalation resulted in a larger net benefit compared with single antiplatelet therapy, and therefore such benefit in the context of higher risk for bleeding implies a probable reduction in ischemic events. The significance of this analysis is that currently patients with ACS and PCI are recommended to receive 12 months of DAP, but tailoring the duration of this dual antiplatelet therapy on individual characteristics for ischemia and bleeding events is an option. Now, shortening dual antiplatelet therapy carries a 2A recommendation while de-escalation is given a 2B. These results, showing basic equivalence, challenge this ranking as de-escalation showed a similar risk of death, a reduced risk for net adverse cardiac events compared with the short DAP regimens. Now, there are limitations. These were indirect comparisons with assumptions. The authors say the transitivity assumption was met, but it's hard for me to understand exactly how that is known and if it is totally reasonable to make these indirect comparisons. On Twitter, I was discussing the complexities of using the language of transitive function in a paper, and David Cohen, an interventionalist and academic, showed a slide that he showed during a talk at ACC. This slide showed how Harvard basketball might be better than Duke by transitive logic. He showed the slide that Harvard had beat Boston College. Boston College had beat Maryland, and Maryland had beat Duke. So by this logic, we can infer that Harvard is better than Duke, which is kind of crazy. So possibly the studies, or in this case, games, were not entirely poolable. Now, my final comment about this is, having looked at the post-PCI studies and the complexity of this network meta-analysis, I am not sure we are ever going to be able to reduce post-PCI antiplatelets to an algorithm. I may be wrong, but there are just so many variables. I mean, think about it. You have the PCI factors. You have the skill in placing the stent size, how many stents, their location. You have patient factors, bleeding risk, MACE risk. You have drug factors. You have different drugs with different potency, different durations, different combinations. I mean, the average effect from trials is going to get us in a ballpark, but I think docs are always going to have to individualize in this case. And finally, always remember, friends, that here we're talking about ACS and acute MI, and stents save lives in this situation. But for those with stable coronary disease, we can completely avoid these complexities if we treat coronary disease medically, which is just as good for mortality, prevention of MI, and probably in many cases angina reduction. Top-line results of a study to be presented at ACC as a late breaker were released this week in a press release. It concerns lipoprotein(a), which is a low-density lipoprotein with an added apolipoprotein, hence the A. Now, etiologically, it may have provided a survival advantage by aiding in wound healing and reducing bleeding, particularly in childbirth. An individual's lipoprotein(a) is 80 to 90% genetically determined in an autosomal codominant inheritance pattern, with full expression by 1 to 2 years of age and adult-like levels achieved by approximately 5 years of age. And outside of acute inflammatory states, the lipoprotein(a) level remains stable through an individual's lifetime, regardless of lifestyle. High levels of lipoprotein(a) affects about 1 in 5 people worldwide, and it's a risk factor for cardiovascular disease. There are no approved medications that selectively lower lipoprotein(a), and levels cannot be significantly modified through lifestyle changes. A company called Silence Therapeutics has designed a drug, doesn't even have a name yet, that can reduce lipoprotein(a) in a dose-dependent manner. The drug is a short interfering RNA injection. It works to lower lipoprotein(a) production by using the body's natural process of RNA interference to target and silence messenger RNA transcribed from the lipoprotein(a) gene in liver cells. The Apollo trial is a phase 1 study. Now, this is the earliest type of study, and it found that the short interfering RNA drug maintained reductions of up to 81% out to 150 days. They found no safety concerns, and they also extended follow-up to 1 year. The inimitable Steve Nissen is PI. Now, of course, you know, this is super, super early. Phase 1 is a long way from Phase 3, where a drug reduces clinical outcomes and has adequate safety. But I have to say, I think we're living through a pretty incredible period of drug development in the lipid space. And I don't know if this will pan out, nor whether it will be ultimately affordable, but it is scientifically very, very neat. And so that's it for this week in cardiology. As always, I'm grateful that you listened. And remember, friends, if you like this podcast, give us a rating, write us a little review. These things really help others find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.